Hi, I'm Griffin Baum.
Hi, I'm Temi Sanosola.
And Temi-san, tell us what we're going to be talking about today.
All right, we are going to be talking about a patient where we did a C3 laminectomy with a C4 through C6 laminoplasty for cervical myelopathy.
Tell us some more about our patient.
Right. So she presented with hand numbness, paresthesias, and upper extremity weakness, along with some significant neck pain and balance problems. On physical exam, she had some hyperreflexia as well as a positive Hoffman sign, which painted a clinical picture concerning for cervical myelopathy. This patient did have a history of multiple lumbar spine procedures. However, these did not really explain her current myelopathic symptoms. And importantly, while clinical observation of these symptoms can be very suggestive of compressive pathology, we wanted to get some imaging as well to both identify the area of compression and supplement thorough history taking and ruling out other causes of cord compression. This is particularly important because cervical myelopathy has many symptoms that are common with other disorders, including multiple sclerosis as well as peripheral neuropathies.
So talk us through this imaging.
Here we have some pre-op sagittal slices of T2 weighted MRI. And here you can see through these different cuts that, one, we can check if there are any pathological changes within the spinal cord, helping us rule out non-compressive pathologies. In this case, we are seeing some compressive pathologies. So here we have our sagittal slices pair with an axial slice. And here's at C4 to C5, we're seeing some flattening of the cord, highlighting the presence of some cord compression at this level, which matches with the sagittal cut. And at C5, C6, we are seeing some flattening of the cord, but also some foraminal stenosis, which is present along with that cord compression. This is due to some spinal stenosis.
Absolutely.
Cervical myelopathy, this is something that classically has an insidious onset. Research tells us that untreated patients are likely to progress with a risk of decline estimated at 20-60% over a period of 3 to 6 years. So that's something that makes us want to be very vigilant in the case of a patient potentially suffering from cervical myelopathy. One thing we also know is that surgical management, specifically for cervical stenosis, is associated with not only prevention of further neurological decline, but also can contribute to improved function for these patients, therefore a better quality of life. This patient was a good candidate for this intervention because, in addition to her symptoms, she was young, she had no structural issues or kyphosis, and she did not have a history of nicotine use. And given the fact that she had congenital cervical stenosis with symptomatic cervical myelopathy with radiculopathy, laminoplasty was a great option for maintaining her motion while also allowing for maximal decompression.
Absolutely. Given all this information, what did we decide to do? What did we recommend?
We initially planned a C3 laminectomy with a C4, C6 laminoplasty. We also planned a C5, C6 left-sided foraminotomy to address that foraminal stenosis that we also found.
Definitely. Let's go to the tape. So tell us about the surgery.
Laminoplasty is a posterior approach. As you can see, we like to mark off, we're working superiorly and inferiorly from, so you see that C2 and C6, and in between we have markers marking off those spinous processes. We're also operating midline, so one thing you'll see is we found that midline raphe and followed along with that, allowing us to, one, prevent injury to the muscles as well as limit the amount of blood loss.
Absolutely.
Right now we're looking at the spinous processes that have been exposed. Using that monopolar is, again, allowing us to minimize that blood loss.
Absolutely. I think it's important to note that in laminoplasty, you don't have to leave a large cuff of tissue in the midline because it really does not provide any sort of support. The most important thing from a surgical standpoint is to not disrupt the insertion of the extensors on C2 and C7.
Exactly. We can dissect out to the lateral mass laminar junction, but not beyond, so as to not disrupt the facet joints.
After doing this, tell me what is going to be the next portion of this operation.
Here we're performing our C3 laminectomy. First he went through with that Masonic bone scalpel, and then you can see now he is releasing some of that ligamentum flavum. Usually you do that a little bit below the lamina, which allows you to remove that lamina.
Now, this technique is called the open door technique. And tell me the difference between how we treat the ipsilateral side versus the contralateral side.
So on the ipsilateral side, where you're seeing the most compression is where we're going to have the opening trough. So in that case, we're slicing or cutting all the way through that bone, essentially creating a complete fracture. Now on the contralateral side, we're having that hinge trough. And in that case, we're working through 3 layers of the cortex, would be that cranial, caudal, and the dorsal cortex, while leaving that ventral cortex, which is necessary in order to induce that green stick fracture. So inside the open door, we're also able to perform our foraminotomy. We're taking, the medial quadrant of both IAP, which we do first, and the SAP. So it's an IAP of C5 as well as a SAP of C6. All right. So on this contralateral side, we're developing that hinge trough. So we would be careful to not, cut all the way through that cortex because we're going to be developing a green stick fracture. As you can see, there is a notching technique that we're using. We're working at the superior aspect of the cortex, the inferior part of the cortex, and we work a bit dorsally as well to get through some of that cortex while leaving some at the end.
Yeah, it's important to remember that these lamina are three-dimensional.
Mm-hmm.
And so they have a ventral cortex, they have a cranial and caudal cortex, and they have a dorsal cortex. And really, we're taking away all except for the ventral cortex. That's really the most important thing. And if you don't release that cranial and caudal, you'll never be able to elevate the lamina like this and to get that green stick. Talk me through the technique for elevating the lamina in a safe manner to avoid spinal cord injury.
So as you can see, our surgeon is placing his thumb on that spinous process, as well as using an upgoing curette to gently introduce some tension as we're creating that green stick fracture. However, this is all in a controlled manner as to not introduce a complete fracture and therefore destabilize this laminoplasty that we're working on.
Now, and when we were editing this, I made sure that you would include this because one of the more difficult things is the instrumentation, which is a bit counterintuitive because the instrumentation really does not provide much biomechanical strength. It really only is designed to hold open the lamina. And what you can see here is that when you can get an excellent decompression, but we also depend on these small titanium mini plates to hold open this area. Now, despite this decompression, unfortunately, the plates can sometimes be a bit one size fits all, which leads to the feared complication that we will realize here in just a moment, which is it is possible to completely destabilize that hinge trough. In fact, the green stick fracture becomes a complete fracture, and what was a laminoplasty now becomes a complete laminectomy. Despite trying some different size plates, a plate without a throat, as well as also considering a hinge plate, ultimately, what do we decide to do here?
In this case, we realized that a laminoplasty at that level was not going to be stable. We also know that even with removing C3 and C4, that with this fixation at C5, C6, this laminoplasty would still be stable, and that patient would therefore also have reduction of our symptoms.
Yep. Really, it becomes quite apparent. The best thing to do is to complete the C4 laminectomy.
The placement of the plate and screws somewhat depends on the system being used. In this particular system, we place a screw and then hook the plate onto it, which allows for good control. The green screws, which are the laminar screws, are 4 millimeters in length and 2 millimeters wide. However, in the lateral mass, we have screws that are 8 millimeters long, which are more of your long and strong screws, which are anchored in.
Really no difficulty whatsoever getting these small screws in. And here you can see I place 2 screws in the lamina, 2 screws in the lateral mass. I've actually changed my technique to only place 1 because I found it's perfectly sufficient and strong, even out as far as 4 or 5 years.
After fixing this final plate, we're going to want to make sure that we address any leftover bleeding. And then subsequently, we're going to add in a bit of vancomycin powder, which will help prevent any subsequent infections before closing. As you can see here, by manipulating the patient's head in the Garner-Wells tongs, we have maintenance of motion.
Yep, absolutely. I do work with a plastic surgeon here in New York who helps for closure, but really a very thorough closure where you reapproximate all of those paraspinal extensor muscles is really of paramount importance. So Temi-san, tell me a little bit about the postoperative course, the hospital stay,
Yep.
what the expectations are.
Right. So in a laminoplasty, typically we expect the patient to remain in the hospital for anywhere between 1 to 2 days. In this case, this patient was discharged on postoperative day 2, and reported improvement in symptoms beginning 6 weeks post-op. At 24 weeks, she reported markedly improved symptoms and was also improved with her quality of life. If we take a look at her post-op imaging, you can see that there's no heterotopic ossification, there's no inadvertent fusion, and the instrumentation is intact and in the correct place.
Despite my angst at the time of surgery, you can see that performing a C3 and C4 laminectomy really did not leave the patient any worse for wear. In fact, in many ways, helped optimize her decompression. This patient's now more than 2 years post-op, and on last visit, she said that she actually forgets that she had neck surgery, which is really the whole goal of laminoplasty, is to maintain normal range of motion. Any last thoughts about laminoplasty? What did you learn editing this video?
Yeah, so in terms of editing this video, I think I was able to learn a lot. This is a particularly interesting surgery in that there's a laminectomy, there's a laminoplasty, there's a foraminotomy, all performed within one procedure. So I was able to learn a bit about each of those simultaneously. I think learning the more importance of various techniques, whether that be how we're working through the different cortices in order to introduce that hinge trough, thinking about the insertions on C2 and C7 and how important that is, and to prevent that postoperative neck pain, and making sure our patient remains stable. And yeah, there's so much to learn. It's hard to even go through all of it, but I appreciate it.
It's a great operation in working with students like you and residents and fellows. This really contains what I think are the two critical skills for posterior cervical surgery: laminoplasty and a laminoforaminotomy. You can help patients in ways you can't imagine, while still maximizing their quality of life and avoiding postoperative morbidity. Great job.
You as well.
Thanks.